Hello, everyone. Welcome to the Physio Almanac. The topic for today's session is one of the most awaited topics, that is the cardiorespiratory assessment. Without any delay, let's begin. So, in the cardiorespiratory assessment, as we have done previously in the musculoskeletal assessment as well, you have to present the hypothesis if you are giving an exam. If you are not giving an exam, if you are doing it in your own clinic or private practice or aged care settings, wherever you work, it's a good idea to have this information with you and kind of a plan before you go and see the patient. So I'll just tell you about what is BAR stands for. I is for identification, S is for the situation, B is the background, A is the assessment, and R is your recommendation or your treatment. All right. Now, specifically, when you are seeing a patient who has been referred for your cardiorespiratory condition or has been referred to you for a cardiorespiratory assessment, you have to think about whether the patient has had similar episodes previously, because that would give you an understanding as to what education component you need to focus on when you are seeing the patient, right? Because if the patient has had a similar episode, sorry, I'll just go back to the previous slide. If the patient has had a similar episode before, so you get a understanding that there's something missing in the patient's treatment plan or something that he is not able to understand, which are leading to similar episodes or exacerbations, and you have to consider that as one of your components of your treatments. You also have to understand whether the patient is smoking. Smoking cessation forms a very, very important part of what we do as physiotherapists. And the reason that I say that, because I'm sure all of you are aware that smoking affects the lungs to a great extent. I'm not saying that all lung cancers are caused by smoking or all lung disorders, and as a result of that, indirect cardiac disorders or cardiac conditions as well are caused by smoking, but smoking is a big risk factor for many of the conditions. So cessation of smoking is one of the important education components that you should be talking about in your treatments section, especially if patient has not quit smoking. All right, coming to pulmonary rehabilitation. Now, pulmonary rehabilitation is a component of your treatment and one of the components of your treatments. And it's a program for lasting from, let's say, 4 to 12 weeks. It varies between hospitals and settings where you work. But the most important parts of a pulmonary rehabilitation program is your exercise and education. And exercise would be aerobic exercises or strength training and things like that. And the education component is smoking cessation, for example, or maintenance of a healthy lifestyle, or prevention of a sedentary life, and things like that. But the main components is your exercise and education, and also it's a fixed duration for which it is performed. So it's important for you to ask the patient, has he ever got an enrollment, or has he ever enrolled himself into a pulmonary rehabilitation program? And again, that would form a basis of our future treatment strategies, or even when we are talking to the patient and discussing about a current treatment plan. If this is something that the patient has not done before, it would be helpful for us to highlight the importance of pulmonary rehabilitation. All right. The last thing that you have to remember is whether the patient has an action plan. So, when a patient is admitted to the hospital, many a times, let's say about asthma or COPD patients would have an action plan, and patients who have angina as well, they would have an action plan. So, and ideally everyone should be having, especially patients who have those conditions. What we are trying to think that whether the patient is aware of what actions or what activities that he might be doing that is leading to an hospital admission or leading to his symptoms getting exacerbated. And if he does, one thing, he must know what to do to avoid them. And second, let's say he lands in a situation where he, unintentionally, he has to do some, let's say, activities or whatever. He leads into a condition, or he ends up into a condition which are exacerbating his symptoms. It is important for you as a therapist to ask, inform, and educate the patient about having an action plan. Because if the action plan is followed, many a times the exacerbation will not become that severe because they would be treated at the right time, and many a times they will prevent an hospital admission. So having an action plan in place is very, very important for patients who have cardiorespiratory disorders. All right. Please feel free to drop me any comments, or and it's very important for me to have a feedback. I've been trying to upload videos and trying to help you guys, but if you can please like, share, and subscribe the channel, so I know the work is being acknowledged. I know that the work is helping people, and it motivates me, to be honest, to do all the good work for you guys. So yeah, I would love to know what's been happening. All right, let's move on. When you're going to see the patient, you have to have a Bogue scale. It's a very, very it's similar to visual analog scale that we use for musculoskeletal assessment of pain. In cardio, we use the Bogue scale. We'll discuss that later in another few slides. We also have to have a stethoscope, oxygen cylinder if the patient is on oxygen, a towel, and a portable pulse oximeter for you to be able to assess the patient's oxygen saturation. All right, moving on. Subjective assessment. So, as we know, we are going to see the patient. We are meeting the patient for the first time, and let's say we are meeting the patient for the first time, right? And the patient is admitted to the hospital. So it's important for us to first of all read the case, read the file notes that have been given. And if you're giving an exam, you would have covered that in the hypothesis part. If you're not giving an exam, you are working in a hospital and going to see the patient, it is still important for you to read the file and have a background information of the patient from the file, from the nurses, from the doctors, handover, whatever works, to have knowledge of why you're going to see the patient. So that's your for you. But when you go and see the patient, you would also have to ask some questions, which are as follows. And I would really suggest asking the questions to the patient, or maybe briefly summarizing about what you know is important, because it helps to assess the patient's cognition level as well. So let's say you're seeing the patient who's just had a rib fracture, he does not know why he's admitted. So probably if you have to ask him about his pain level or his cough, you cannot be having a reliable answer because his cognition is poor. So when you start with the first part of the assessment, after the ID check and after the name and date of birth check, it's important to get a idea of the patient's cognition. So when you see the patient, whether for the first time specifically in a hospital or a private setting or wherever, the questions that should be asking: what brought you to the hospital? Or what events led to the hospital admission? Or what happened before the hospital admission? Now, cardiorespiratory assessment, you have to think of cases can be acute cases, that is, the patient may have an acute exacerbation of COPD. So it's not really acute, but it's acute on chronic, because COPD is a chronic disease, and we know if the patients are not managing themselves, we know that it can lead to hospital admissions, that I was talking to you about few minutes ago, about having an action plan. So if you are seeing the patient in a hospital admission, it is very important for you to know what brought the patient to the hospital if he's coming by himself, or what led to the hospital admission, or what led to the exacerbation that the patient had to have a hospital admission. So cardiac cases, as I was saying, they can be acute or chronic. COPD exacerbation, let's say, they can be acute cases, for example, a rib fracture, or let's say a pneumonectomy. So that's a surgical case. It's not really an acute case, but it is a uh, acute case because he's had a surgery. So things like that. He does not, probably may not be having any underlying surgery, or underlying conditions. So it's very important for you to understand and modify your questions about the patient, or questions that you're going to ask in the subjective assessment, depending on where the patient is. Right? If the patient was in the clinic, you would probably ask, hello, Mr. X, my name is W, and I'm here to help understand your condition, and I'm here to assess you for the symptoms that you are having. So can you tell me what brought you to the clinic today? Or if you're in the hospital setting, you may say something, hello, Mr. W, my name is X, and I'm going to be your treating physiotherapist for today. I'm here to understand some of the things that are concerning and affecting you in terms of your breathing and your physical capacities. So do you mind if I start by asking a few questions, and then we can begin with the other part of the assessment? So, something like this. So, it's always a good idea to introduce the patient, ask them about what problems they are having, introduce you yourself and why you are there, and then you start asking questions. All right, very important to ask the patient what are the main problems today. So, you are seeing the patients today, and it's important for you to understand what are the concerns that they are having. And remember, we have already asked about what led to the hospital admission, why was he brought to the hospital, and then you ask about the following questions. All right, can you tell me what are the main problems that you are having today, so that I can help to treat, it will help me to treat you better, or so that I can modify my assessment accordingly. So now, in cardio, the main symptoms, or the main things that you have to ask about, when I'm saying cardio, I'm referring to this assessment, cardiorespiratory. You have to ask about cough, you have to ask about sputum, you have to ask about shortness of breath, and you have to ask about wheeze. All right. Now, please remember, if this is a surgical case, the assessment would be slightly different. If you need help with your assessment of your surgical cases, please let me know, and I'll try and make a presentation soon for you guys. But as I've told you before, I would really encourage some feedback. And then I can plan my presentations accordingly, as to what you need me to prepare and help you guys with. All right, so cough. Now, when we are asking about cough, the question may be given like, we may ask a question. So, Mr. X, can you tell me if you have any cough at all? So the patient would say yes or no. Now, let's say the patient says yes. All right. So, is it bothering you a lot, or it's not that much of a problem? So, whatever our patient answers, you have to ask more questions. So, can you tell me, when you are coughing, are you having some phlegm, or do you think something is coming out of your mouth when you are trying to cough? So, we are referring to sputum. So the patient would say, yes. All right. So can you tell me, if you've had a chance to look at the color? So can you tell me what is the color of the phlegm that is coming out? So the patient says green. Now remember, we know that if the patient is saying green, it's relating to an infection. If it is yellow, it's kind of getting close to having an infection. So ideally, we would want, if the patient is having sputum, first of all, not having sputum, but if he does have, clear and thin would be the best. All right. But having said that, we do not want sputum in the first place. Okay. Um, also, Mr. Rex, I would like to understand, can you tell me how much quantity of phlegm do you think is coming out on a daily basis? So the patient would probably not understand your question. So you may rephrase it like, do you think it's 1 tablespoon or 1 teaspoon? I'm trying to understand what is the amount of cough that you are producing. And can you also tell me whether have you noticed that it is thin or the sputum is very thick? How would you describe as its consistency? So is it watery? How fluidy do you think your phlegm is? So these are the questions that you will ask about your color, quantity, and consistency. All right. Now remember, when you are asking this question, the question should flow from one to the other. All right. So let's say you're asking about cough. So you ask the patient, do you have any cough at all? Yes, I do. Okay. And then you ask a follow-up question about sputum. Let's say the patient is saying, no, I don't have any cough. So then there is no point of you asking about the sputum, right? So your question should make sense as well. All right. You would also have to understand and ask the patient if, and I'll come to this later, but just telling you briefly, always remember to ask the patient, all right, so the cough that you are having now, has it gone worse just before your hospital admission? Or if you're seeing the patient in the clinic, has this cough gone worse in the last few days or weeks? So you are comparing before and you are comparing now. The same with sputum. All right. So it has always been a green color, or since the last few days and weeks, it has changed its color. Was it always this thick? Was your phlegm always thick? Or in the last few days, you have noticed it to become more thick? Something of that sort. Or in terms of quantity, you could ask, has your phlegm always been this amount? Or in the last few days, you have noticed an increased amount of phlegm? All right. Hemoptysis, we are referring to blood in the sputum. And again, as I said, if the patient does not have any cough, he will not be having any phlegm. And if he will not be having any phlegm, he will not be having any hemoptysis. The question that you would have to ask the patient, have you noticed any blood in your phlegm when you are coughing? Like that. Another important question is about your shortness of breath. All right, Mr. Rex, now I want to understand about your shortness of breath. Many patients may not understand, so you can also rephrase. So I would like to understand if you feel puffed out or if you feel that you have less air to breathe, like when you're walking for a particular distance, do you feel that you need to breathe heavy, or you feel that you need more air? So you can phrase your questions accordingly depending on whether the patient is able to understand what you are saying or not. This question has to be understood as per this uh, concern, like shortness of breath, has to be understand from the patient's perspective as to on rests, and you can observe the patient. You can see whether the patient is having any shortness of breath, but also from exertion. So you would ask something like that. So in terms of your shortness of breath or the feelings of air hunger that you are telling me, do you have this feeling all the time, like even when you are resting, as you're talking to me right now? Or is it present sometimes? And in terms of your shortness of breath, so you were saying you only feel short of breath when you're walking for a particular distance. Is that right? Yes, that's right, the patient says. Okay. Then you would have to ask following questions: that how far do you think you have to walk, or how far do you think you can walk after you start feeling shortness of breath? And do you stop walking or doing your activities because you are short of breath? So these are following questions that you would have to ask. Also, as we were talking about the Bogue scale, I have the scale on the next slide. We would also have to assess how much shortness of breath the patient is having. You can use it on a 0 to 10 scale if you do not have the Bogue scale with you, but I would strongly advise to have a printed version of the Bogue scale with you, especially for when you're seeing cardiorespiratory patients. All right. Again, as you were talking about cough, if there is cough, then only there will be sputum. The same way, if there is shortness of breath, only then there would be wheezing. Uh, except certain cases um, who may have other conditions causing the wheeze. But how would you frame this question? So when you said you're feeling short of breath, have you heard any whistling sounds, or have you heard any noises, like as if wind is trying to come out or the air is trying to rush out from your lungs? So if the patient does not understand the word wheeze, many patients who have asthma, they usually understand the term. All right, moving on. I hope this is all good. So remember to ask about what led to the hospital admission, or why is the patient in the hospital, or why the patient is in the clinic. Ask about cough, sputum, shortness of breath, and wheeze. The Bogue scale. This is so the Bogue scale. There was a original Bogue scale that was from 6 to 20, and there's a modified Bogue scale. So this is from 0 to 10. So how I would ask the patient. So you were telling me about having shortness of breath, Mr. X. This is a scale which we call the Bogue scale. If you can see, it describes how you are feeling when you're feeling short of breath. So let's say 0 is no shortness of breath, or you feel nothing at all, and 7 is very severe shortness of breath, and the 10 is maximum or maximal short of breath. How short of breath do you think you are now at rest? And how short of breath, or how bad your shortness of breath gets? Now, the instructions from Lung Foundation is: this is a scale that asks you to rate the difficulty of your breathing. It starts at number 0, where your breathing is causing you no difficulty at all, and progresses through to number 10, where your breathing difficulty is maximal. How much difficulty is your breathing causing you right now? Right? So you can ask the question. This is the whole point. You have to ask how short of breath, or how difficult it is for you to breathe, or air hunger, as I was saying, or you feel you have no air in your lungs. You can modify the questions depending on what the patient understand. But having a printed version with you to show the patient, it's always a good idea. And I normally give the patients a handout of the book skill, because I think it's important for them to understand how their symptoms are even when we are not there. All right, moving on. Always remember, we have to compare before and now, as I was talking to you briefly, in terms of your cough, in terms of your sputum or phlegm, in terms of your shortness of breath, in terms of your wheezing, in terms of your walking distance, whatever things that you're going to be asking in terms of your cardiorespiratory assessment that are describing how the patient symptoms are. Always make sure to compare them before and now. An important point is, how far do you go? So let's say the patient has had was riding a horse and he fell from the horse. He had he's got a rib fracture, and he's a 21-year-old male, right? So how would you put this question as? So I can see you do not have any past medical history of any cardiorespiratory disorder. So, but I still want to make sure and understand. I'm assuming you do not have any problems with your breathing, and you never had any problems with your breathing before, and you never had any cough, any sputum, any shortness of breath. Is that right? So, this is how you would ask. Now, let's say the patient is having COPD, right? And he has been having those symptoms 3 weeks um, before, since he got admitted to the hospital yesterday. So, how would you put the question? So, Mr. X, I know that you were having these symptoms that got really bad 3 weeks ago. Um, so, I've got a fair bit of understanding of how you are feeling right now. But let's talk about maybe before 3 weeks, let's say 3 months ago. How bad were your symptoms? Were they similar? Or how much were you able to walk 3 months ago? Or how much of sputum did you have, or phlegm did you have 3 months ago? So that would be your baseline, right? So modify your questions, modify your before and after, before and now questions according to what is the patient condition, or what is the patient diagnosis that you are seeing the patient for. All right, moving on. It's also important for us to understand if the patient has any other symptoms such as chest pain, fatigue or tiredness, limited ability to perform activities of daily living, any edema in the legs, and how is their sleep going. Very, very commonly, the patient who have cardiorespiratory disorders would have their sleep may be disturbed. They may be waking up at night, which leads to fatigue, and also many a times the medications, and because they are not able to eat properly, and they kind of restrict themselves, so kind of force themselves to have a sedentary lifestyle because they are afraid of the shortness of breath. They have reduced ability to perform their daily living, so reduced exercise tolerance, and they would also report of symptoms that they are too tired and they are fatigued all the time. It may be due to medications, it may be due to their food, it may be due to their lack of sleep, whatever reasons it may be. All right, moving on. We have to find out about the current level of function, that is clof and the plof, and the previous level of function. As I was saying, when you are asking about shortness of breath, or you can ask those questions at that time, or later on you can have a different section wherein you are asking about how far the patient is able to walk, right? So we are assessing the functional mobility or the walking distance. So again, you have to compare before and after, or before and now. How far are you able to walk? Are you able to walk only inside the house, or are you able to go outside? So when you are walking, do you need any rest breaks to catch your breath? And let's say the patient says, I'm just able to walk 40 meters. So what stops you from going more than that? Is it chest pain? Is it shortness of breath? Is it tiredness? Is it pain in the legs? So you have to explore more. So that's the limiting factor. You have to understand what is the limiting factor that is affecting the patient. Also, a good idea to understand whether the patient is using any gait aid. Again, modify your questions according to the patient that you are seeing. 21-year-old patient who was riding a horse, obviously, you cannot be thinking that he may be using a walking aid, right? 78-year-old female who has been admitted due to lives by herself, has been admitted due to acute exacerbation of her COPD symptoms. Yeah, could be using. I'm not saying will be, could be. Always a good idea to ask, right? So modify the questions that you are asking depending on the patient that you are seeing. Again, having a falls in the last 6 to 12 months, important for an older patient, not for all the patients. You do not need that. If the patient has had any physiotherapy treatment before, very importantly for patients, let's say, who have bronchiectasis, we know it's a chronic condition, and or cystic fibrosis, let's say, the patient may be having some physio treatment before. So just give you an understanding what has worked for the patient and what has not worked, and then you can modify your treatment accordingly. Also important to understand whether the patient is having or doing any regular exercises, or is having any regular exercise program from their previous physio, let's say. Moving on, we have to understand about the past medical history. We know that's the thread. So thyroid, high blood pressure, respiratory disorder, epilepsy, arthritis, diabetes, and smoking or surgery. Now let's say, uh, use your gray cells here. When we are going to see the patient, you already have the past medical history, and let's say the patient has asthma, right? So how would you say the patient? So in terms of your past medical history, I know your main concern or your present diagnosis is asthma, but can you tell me when were you diagnosed for the first time, or if the patient remembers? Or so I know your respiratory condition, that is asthma. Do you have any other re- illnesses related to your lungs, or do you have any other conditions relating to your lungs? Do you have any heart issues? Do you have any thyroid issues? Any arthritis? Have you ever been diagnosed of rheumatoid arthritis or osteoarthritis? Something of that sort, that you can modify your questions accordingly. Also have to understand whether the patient is taking any regular medication. So it may be puffer, it may be any regular oxygen therapy. Please remember, oxygen is a drug. It's like a prescription medication. We as physios are not allowed to be changing the prescription, except the patient when he's in a hospital setting wherein you wean the oxygen. That's a different situation. But let's say a patient has come to your clinic on 3 liters of oxygen, and that has been prescribed by their doctor. We do not change their prescribed dose of oxygen. It's a medication. All right. So many patients, especially who have chronic COPD cases, severe long-standing cases, they may have home oxygen, and they may be having some cylinders. Do not change that prescription. All right. It's important for us to know what is their baseline oxygen level if they are using any. All right, we also have to clear the red flags. So we have to find out if the patient is having any headache, any dizziness, has he had any weight loss in the last few months, any pain at the back of the legs. We are thinking about DVT, any chest pain. So when we are talking about chest pain, patients who have chronic conditions, when they are coughing a lot, they can have uh, issues with their chest, like in the sense they may be having some pain on their chest as a result of chronic coughing. That is different to an anginal chest pain. So make sure, and obviously there are factors, and it would be different to a gastric chest pain, right? So when you ask the patient, do you have any pain on your chest? So the patient says yes. So you would have to explore more. So where exactly do you have the pain? If the patient is localizing the pain, then you are not thinking about anginal pain, right? Okay, so can you tell me, this pain that you are localizing, is it present all the time, or is it only when you are trying to cough? So the patient says, no, only when I'm trying to cough. Or the patient may say, no, I get this chest pain when I'm exercising. That could be your pain, chest pain relating to your heart condition. So try and think broadly about the red flags, right? We are concerned about unremitting chest pain. We are concerned about chest pain that is brought on by exercise. We are concerned about chest pain that is radiating down the arm. And yeah, all right. All right, moving on. Very important for us to know about the patient's personal and social history, which includes your house setup, whether the patient lives in a single story or a double story house, whether the patient lives in an apartment, whether he has any lifts, whether there are any stairs, whether he has any handrails, things like that. Also important to know whether the patient lives by himself or has family members living. And if the family members are living, are they able to help him? Or if, let's say, the patient is very deconditioned and you have given him an exercise therapy program, but the patient would be better off having someone supervise him. That's why it's important for us to know whether the patient is living by himself or he has family members. Also important to know about the patient's hobbies. What does he enjoy doing? What is he not able to do as a result of their rib fracture, let's say, for example. Or the patient is not able to do as of now, COPD cases I'm thinking about, and they were able to do 3 months ago, right? So there has been a deterioration in their lung function, their physical function, and hence they are not able to enjoy their hobbies. Also important to know whether the patient is working or not working, whether the work is getting affected. And obviously, we will have to modify our treatment and the intensity or the extent and the duration of the treatment, and depending on what the patient's problems are. And if one of the problems is that he cannot go to work because he has so much of cough and phlegm, then obviously we will have to change our treatment accordingly. We have to find out about smoking if you have not found out um, about that in your past medical history section. Since when the patient has been smoking, how many cigarettes in a day, and whether he has thought about quitting. We are not there to judge the patient, we are just there to ask the patient, have you ever thought about quitting? Yes, I've thought about it, but I couldn't um, continue. And I had a relapse and I started smoking again. I'm so sorry to hear that, Mr. X. We have a lot of support available here while you are in the hospital, or we have a lot of support available here for us at the clinic. If you have thoughts about quitting smoking, please let me know and I would be able to guide you to the right person. And we end there. All right. Our session is not relating to smoking. Our session is relating more so to their physical function and their respiratory limitations. So let's focus on that. Moving on. These are some asthma and COPD medications that are from the National Asthma Council. Importantly, you have to remember that the patient may be having a blue color device, which we call the Ventolin. And this is a short acting beta 2 agonist. So that has immediate effect, immediate relief of shortness of breath is provided by this medication. So, if the patient is telling you that he has shortness of breath and he has a diagnosis of asthma or COPD for which you are seeing the patient, make sure to ask whether they have their puffer and cite it. So, just say, can you show me where your puffer is? You have it in your pocket. Okay, can you please keep it out on the table so that if we need it, we can use it. All right. Now, many of the hospitals and the clinics around here in Australia are recommending the use of a spacer, and it's actually very beneficial. I have seen many patients getting benefited when they use a spacer instead of the device, the inhaler by itself. And just because of the simple fact that When you are using a spacer, it helps to direct the medication around and into the lungs rather than going into the gastric system and getting absorbed and not helping the patient. So, let's say the patient is having an acute asthma attack, he may not be able to coordinate his breathing and pressing of the device to get the medication in. When you have a spacer, you can just press the device, the medication would be stored in the spacer, and then you can breathe as per your own ability. So evidence suggests that using a spacer would help and helps to have more widespread distribution of the inhaler medications into the lungs. So it's evidence based. All right, moving on. We have to talk to the patient about their goals. We know about the long term goals. We can be thinking about what are the hobbies that the patient is not able to do, and if we can help them to get back to their hobby. So that's how we are thinking about the long term goals. In short term goals, what are the main problems today? So let's say the patient is having a lot of cough, chest pain when he's coughing, he is not able to walk for a long distance, he is not got out of the bed since surgery. Problems that are of the main focus as of now need to be addressed and set as short term goals. All right. I think I will end here. I was thinking of continuing with the objective assessment in the next session. So after today, I would be uploading the objective assessment pretty soon, and the treatment component, we'll try and put both those together. And I hope this was very helpful. I would strongly recommend you to go and read about the assessment again. Please get back to me if you have any questions. If you think there's a area that you need more explanation on, I am more than happy to help you. And thank you. I'm so glad that I'm trying to do my best to help you all. And yeah, please look forward to the second part of the assessment. I will see you all soon. Thank you.